Good afternoon, everybody. Hello. Welcome to the Health Equity Network webinar. We have 90 people signed up to attend, so we've got somewhere to go still. How many have we got at the minute? 22. So if you don't mind hanging on for a few minutes, we'll just let a few more people join. And don't worry, we will end at 1:30 at the latest.
Hi everyone. If you could also, be sure to mute yourself while the speakers are talking, just to be sure that we can hear everyone clearly. Thank you.
The more recent people have joined. We're just allowing a few more minutes to let other people come on the call. Hi, Jessica. Hi, Veronica. Wow, just taking in that background from Somerset. That looks nice. I could completely put my foot in it, but is that like Cheddar Gorge or something? I got lucky. We're at 35. Another minute. For the people who've just joined, we're just allowing a bit more time for others to come in. We had 90 people signed up, and of course, not everybody is able to attend. I'd like to get to half that number. Okay, I'll take one more and then we'll get going. Here we go. Right. We have 41 people. Welcome, everybody. Good afternoon. I think everyone in the country is probably experiencing the frost and sunny day, and it all looks lovely. I have to say I haven't stepped outside the door, so I don't know what it's like outside, but it looks good from where I am. My name is Alan Higgins. I'm the Health Equity Network lead, and the other people on the call that help me work on this are Alison Biedron. Do you want to say hello, Alison?
Yes, hi everyone. I'm Alison Biedron. I'm the Health Equity Network coordinator. You probably get a lot of emails from me, but we're really happy to have you all here today.
Excellent. And Louise, would you like to say hello as a co-presenter today?
Hi, thank you, Alan. Yeah, Louise Marshall from the Health Foundation.
Excellent. Right, great. So we have 45 people on the call so far, which is excellent. There may well be a few more people joining, so you'll keep hearing that noise for a while, but that will then settle down. So thanks very much for joining us here today. And what we're looking to discuss today is about developing the narrative for the movement for health equity. And you'll have picked up from what we've been posting on the Health Equity Network over the last month or so, is that developing this movement is one of our key themes. And it was a key theme when we had the conference in Birmingham, and we had some great inputs about what makes a movement, how do we develop a movement. But it is one of those elusive things, how you start a movement, what the key aspects are that start a movement. And anybody who looks at social movements will soon pick up that most social movements don't succeed. There's many that start and then fail, and there's also the ones that you'll hear about, which of course are the ones that tend to have greater longevity to them. So if you've been on the webinar before, you'll know that we like to keep it very informal. If possible, keep yourself on screen. We do need to keep with the rule that if you're not talking, if you can stay on mute. But there will be an opportunity for everybody to contribute in the last half an hour or so of the webinar. And the way this will run today is that after this introduction from myself, we'll hand over to Louise Marshall from the Health Foundation, who will take us through a presentation of the work that the Health Foundation has been doing with frameworks about how you communicate about social determinants, wider determinants of health. After that, I'll do a brief 10-minute run-through of what I have picked up. I'll try to improve that while Louise is talking. Thanks, Edward. And then so I'll run through that, and then hopefully that will set up the discussion. So I will go off screen while I try to improve my my audio. And but I'll hand over now to Louise.
Thank you so much, Alan. And now I'm going to do that slightly embarrassing thing where I work out screen sharing again. You'd think after 3 years of this, I'd be a dab hand, but it always requires a bit of thought. It tells me it's loading, tells me it's working out a few details.
Looks good.
Great. Okay. Can you see it as a screen share? Because the last time I did this, it kind of ended up taking over both my screens and I couldn't see anything. Ah, here we go. It's finally loaded up properly. It's showing as a slideshow. Excellent. I've got a thumbs up from somebody. So that's great. So yeah, so I'm Louise Marshall from the Health Foundation. I'm a senior public health fellow there and public health specialist in the part of the organisation that we call the Healthy Lives team. So very briefly about the Health Foundation, for those of you who don't know us, we're an independent charity committed to bringing about better health and healthcare for people in the UK. And we're the second largest foundation after Wellcome working on health in the country. And our work on the wider determinants of health inequalities, which is where the work I'll speak to you about sits, is one of our newer areas of work. So historically, we focused pretty much entirely on the NHS, increasing on social care, but we've been building up this programme of work on the wider determinants of health and inequalities over the past 6 years. And our aim really through this work is to change the conversation to a focus on health as an asset rather than ill health being a burden, and to promote policies and local action as well that improve opportunities for health, healthy life in the UK. Has that scrolled on? Seeing nods, excellent. Always worth checking till I get halfway through and realise that nothing is moving. So I think in the course of developing this programme of work and what we might do, I think we quite quickly realised that despite very compelling evidence about the role of the wider determinants of health and the sort of clear story that we felt we were developing, we really rapidly found that this was struggling to get cut through in public media and political debate, and people's attention too quickly turned to what individuals should do in terms of their behaviours and what the National Health Service could do rather than thinking about prevention. So at the Health Foundation, we decided we needed to frame our health communications differently and to tell a more powerful story, a story that would increase understanding about the role of the wider determinants of health and help build support for the policies that are needed to reduce health inequalities and improve health across the country. So we commissioned Frameworks UK to undertake some research to help us understand, firstly, how people think about health in the UK, and then to develop new ways of talking about the wider determinants of health and inequalities. So these are just the 2 phases of the research, and there's a link there, but I can post that in the chat later on. So you can actually click on it, so don't worry about writing it down, and really happy that the slide is shared. Overall, in the research, more than 7,500 people from across the UK were involved in some way or another, and that was a representative sample. And yeah, you can just see on the screen there's the sort of different methods that Frameworks undertook in engaging people in that work. So before I go on, just a quick word about framing and why it's so important. So framing, we're doing it consciously or subconsciously all the time. So it's the choices that we make about what we say, about how we say things, and importantly now, what we leave unsaid as well. And these choices always affect how people think, how people feel, and how they act in response to what we say or write. These frames the frames we use can shift how people make sense of an issue, and that includes what kind of solutions they might support for that issue. And it's a key part of social change in that way. Frames can be used and they can be adapted to a variety of different contexts while talking about the issue in a consistent way. So I think it's quite helpful to think about them as a scaffolding. So frames are really, they're messages, they're not messages, rather, they're ideas. They're sort of a scaffolding, which a whole field of practice can use to structure their communications. But while doing that, you can still, as you would with any communication, tailor these to your audiences. You can dial different elements up or down, but always fundamentally using those same underpinning ideas. And this is one way I believe a movement for health inequalities can make a big difference in shifting mindsets for social change. So it's not about saying everyone needs to say the same thing in the same way. It's about using a consistent framing to support the same story, to shift understanding in the same direction, and to make sure our messages and the understanding that we're trying to create among those who receive our messages take hold. So we sort of want to move from our communications as a field, pulling in lots of different directions, if you like, to some broad alignment. So, yeah, as I said, not everyone saying exactly the same thing in the same way, but a broad shared direction to communications. And it's when that occurs that you can start to see shifts in mindsets and understanding. So back to the research that we undertook with frameworks. The first phase of that was to understand the mindsets that people in the UK hold about health. Now, mindsets shape our understanding and our actions really without us realising. They guide our expectations about how the world should work, and they're activated by things that we see and hear around us. So given that these, the list on your screens are the dominant mindsets that our research found that we hold about health in the UK. So, you know, it's about the choices we make, it's about willpower, it's about discipline, it's about not being unwell, and when we are, it's about the NHS. And, you know, if we want people to make better choices, I use that term with these speech marks, then, you know, it's about educating people, telling them what they should do. So I think, you know, given all of that, it's not really surprising, perhaps, that we don't readily think about the importance of action on the wider determinants of health when we think about how to improve health and reduce health inequalities. So given that understanding, the second phase of the research then moved on to developing and testing ways to expand this story about health, to help shift people's mindsets, to open them up to that context, help them see that context, and understand the action that's needed. So in this sort of brief few minutes left, I'll just very briefly outline 3 key recommendations from the research, but there's a lot more detail in the full research report and in our toolkit, and I can paste the link, as I said, to those in the chat when I'm speaking. So yeah, 3 broad recommendations: show why the issue matters, explain what it's about, and be clear about what we can do to make things better. I'll go through just a couple of bits of detail on each of those. So firstly, if we want to increase support for policies and action on the wider determinants of health and inequalities, we need to start by showing why people should care, and we need to be clear that it's a matter of life and death. So frameworks tested several different framings. Some were around healthy life expectancy, some were about living longer. The one that was most effective across all groups of people was one that was around cutting life short, and this being a matter of life and death. So we can lead our communications by clearly stating what's at stake there. So something like people in the parts of the UK are dying earlier than they should, and there are wide inequalities in how long people can expect to live. And then we can connect that statement of that fact with the need to address the social and economic conditions that are harming health and cutting life short. And I know for me, certainly when I started into this work and started trying to implement some of these recommendations, it felt really uncomfortable. I'm someone who's public health trained. It didn't feel like it was in line with the way I was trained and comfortable speaking. And actually, the more I've done it, the more comfortable it feels, actually. And in our toolkit, we've got some sort of examples. I said this isn't just about giving you phrases to use, but there's some examples of ways you can word things if you would find that helpful. So yeah, firstly, why it matters, frame that around cutting lives short, and inequalities in life expectancy in different parts of the country or different parts of your local area. So secondly, it's really important to explain. So most people don't understand exactly how the world around us shapes our health. So we need to explain very clearly and to link cause and effect. So, for example, if you say, education is important for health, people assume that's around education about what we should eat and how much we should exercise. They don't see sort of higher levels of education and understand how that fits to how that leads to better health. So use a kind of stepwise explanation, a deep dive potentially into some areas. The research found that talking about jobs or housing work well. Use words like cause and as a consequence and because, and take your listener or the person you're communicating with in a sort of stepwise journey from how some of the conditions of our lives leads to poorer health and shorter lives. And talking about the role of stress actually was quite effective. So, for example, the stress of not being able to make ends meet, and talking about how kind of chronic stress can have physical health impacts, and that was found to be something that sort of opened up people's understanding quite well. And also using metaphor. So again, Frameworks tested several different metaphors, and the one that was the most effective in building this understanding about the wider determinants and how they operate was around building blocks. So you can now talk about the building blocks of health rather than the wider determinants of health. It's a bit less jargony, but also helps people to understand how together they interact and give a sort of firm foundation, stable foundation to people's lives. And then lastly, the third of these sort of 3 steps is to show that change is possible. If you don't get to this point, people get quite fatalistic. They think it's all too big and complicated to solve, and it's just the way the world is. So really important to pair your explanations about the issue with solutions and what those solutions might be. Show that we can change this. It's not inevitable. And bring that solution in early and really kind of, explain in that stepwise way as well how it can lead to improved health and reduce inequalities. And then lastly, use some really concrete examples, but don't just come up with a sort of arm's length link of list of policy solutions. So yeah, as I said, we have published this as a toolkit and a sort of full research report as well. I'll share the links. Just to add that there's a lot more depth to the recommendations in that, and as I said, some examples of how you can use them in your own communications. And there are a few areas that I'll just briefly mention that we looked at a bit in more detail in the research that I haven't had time to talk about today, but those are racism and discrimination, the impact of those on health. How we can bring the NHS into our communications about health inequalities and the wider determinants, and also talking about the pandemic, which landed right in the middle of this research. So thank you so much for your time. I'm looking forward to Alan's presentation and to the discussions, and please do feel free to drop me an email if you'd like to discuss this any further.
Excellent.
I'll just stop sharing. I'm going to stop sharing. There we go.
That's great, Louise. Thank you so much for getting it started. And like you said, when I went through the toolkit, I actually found it uncomfortable. I was having to think about the way I talk about wider determinants, social determinants of health. And I would need to kind of retrain myself a bit to communicate in that way. It did make me think of when I was a director of public health and I was presenting the annual public health report to the board for the nth time, and I had line graphs going up or down, whatever, and I was thinking, oh God, I'm bored with this stuff, and everybody else in front of me looks bored with it as well. And I decided then that that was the last time I would use graphs, and I shifted to infographics. So actually thinking about the way you communicate is important. I hope the audio is better than it was previously. Oh, that's good. I've got a mic in front of me like I'm a DJ. So. Good for me. Right, I will now move on to a 10-minute presentation about social movements. And slideshow. beginning. And I could do with a thumbs up or somebody speak just to let me know that that's all there. Thank you.
Yes.
And excellent. So I will say from the outset that this is a less evidence-based presentation than the one that Louise has just given you. And this is more about my experience from about 10 years ago when I was working in Greater Manchester looking at how we might start a social movement on health equity, but based on using arts techniques. Community arts particularly was the thing that I was interested in at the time. And you may have noticed that we didn't actually succeed in doing that, but we actually learned a lot in the process of doing it. So I'm going to use some of the experience I had from there and some of the theory I picked up about social movements to hopefully spur this conversation on. So I can't actually see the chat, but I'm going to encourage you while I'm speaking. If you want to log, you'll see the first few slides talking about social movements. Then if you want to log social movements that you particularly remember or even are part of currently, then that would be nice to see as well. So first one, if I can get the move. You're gonna have to speak up and come on for this one. Anybody recognize what this picture is from? Come on, Mike, and shout out if you do.
Is it Wales and the collapse of the mining structure and the burying of children?
Not.
The Great Ramble on Kinder Scout.
There you go.
Yeah.
Thank you, Tim.
Or the Great Trespass, correctly, yes.
Kinder Trespass. Thank you. Thanks, Felicity. That was a good guess. 24th of April, 1932. Kinder Trespass, for anybody who doesn't know, it was when a group of walkers from Manchester walked up Kinder Scout and met walkers from Sheffield. It was up to this point, and then after still, not allowed for walkers to trespass on this land. But this is recognised as a very successful act of civil disobedience, and in some ways a social movement. Eventually led to the National Parks legislation in 1949, and then some years later can be linked through to the Countryside and Rights of Way Act in 2000. And that's just a way of suggesting that, you know, social movements sometimes start without having necessarily a fixed goal, but and may take some time to be successful. And this one, there's a couple of pictures on this one. Like me, and I'm sure many of you have been to Amsterdam, and as a cyclist, I really appreciated the cycling infrastructure that exists there. And I had to say, I'd taken it for granted that this was an act of far-sighted planners, transport planners who decided that cycling was a good thing to promote. And it was only when I looked into it a bit that you kind of start coming across a whole story of a social movement. And this is a picture from, as it says there, cyclist mass die-in outside the Rijksmuseum in the 1970s. And there's this one, I don't have a Dutch accent, so Stop de Kindermoord, which translates as Stop the Child Murder. And this was protest, a social movement, there's another one there, occupation of a meeting there from children, which was fired up by a sense of injustice around the number of children who were being hurt, killed by car driving. And so this social movement, you can find a lot more about it if you look into it on Google. It's led to the kind of establishment of the cycling infrastructure which we have in Amsterdam these days, but it has arisen. We've got to this point as a result of people taking this kind of action. Another one here, which people often cite, is about engagement in HIV/AIDS social movement in the 1980s onwards. And again, it's often quoted as being something that people in public health had their initial engagement in social movement activity from engaging in asking for further research on AIDS and other things too. And a more recent one is the Me Too movement, an ongoing movement, started around 2006. Which is, of course, a movement protesting against sexual abuse, harassment, sexual violence of all sorts, and is continuing to this day. And it's good to have this one because it shows that not all social movements happen in black and white. So those are some of the ones that I'm familiar with. And please do, if there's others, please post them in the chat. I'll be interested to see them. So Marshall Ganz is somebody who has written a bit more about social movements, and his writing is saying social movement, a reaction against injustice, draws people together, empowers action for change, brings together a suite of approaches and leadership practices that are designed to mobilize and organize people towards achieving a common purpose. I always love that thing where it says a suite of approaches. Another way you could say a whole mass of things come together to make this happen, but he's identified 5 things in particular which are down that bullet points as well: leadership, relationships, stories, strategy, and action. And there's a few more slides on each of those. For leadership, traditional formal authority isn't going to work. Authority comes through appealing to the sentiments. And that's a key point about sentiments, about appealing to people's passions. What made them get involved in this issue in the first place? What made all of us get involved in health equity? And what makes us come onto a webinar? What are we passionate about here? Based on values of injustice and hope as well, hope being a key thing here. Part of a social movement comes from the people within it. You need leadership, but it's about the people who are actually there. One of the things I reflect on for the Birmingham conference, and I know only 200 odd people of the network, what was the capacity we had. What made it successful was the people who came there. We had great speakers, of course we did, but it was about the people who came there who made the interaction on the day a successful thing. Recognition of our shared past, commitment to a shared future, connecting people throughout shared values, shared understanding, and so on. Hopefully that leading through to shared action as well. Stories. Apologies, these are in a transition thing. At the heart of a social movement are stories, a story of hope about how things should be. And that's hopefully what we're going to be discussing today, about how we get the narrative going. So the story of self explains why I've been called into action, why I care about this. The story of us, why we care. It shows what brought everyone together, that creates a shared sense, shared vision and shared community, sense of shared vision and community. Story of now. This is an interesting one particularly, I think. Let me move that box. It's about motivating people into action. It should create urgency, but give hope by telling the story of the world as it is now and the story of the world as it should be. When I was looking through this, I kept thinking about the movement now about climate change, climate heating, that sense of creating urgency. There you go. Strategy. Strategy is the theory of change, but asking how are we going to do this using existing skills and knowledge. It's also about keeping people motivated. You don't want to get bogged down in strategy. Strategy needs to be continually developing, I think, keeping people's motivation up, keeping their energy high. Action happens by creating a commitment to culture, making things happen on time and learning from them. And that sense of it. This needs organization as well. Having clear, specific goals that are easy to commit to. So those are the 5 features of a social movement as Marshall Ganz identified them. These are 8 core characteristics of social movements, and I'm afraid I find these very useful. I just don't have the reference to hand as to where I picked these up. I could look for those and send them on later if anyone's interested. Bits I've highlighted in red: radical actions, belief that change cannot be achieved within the system. The system itself has to be changed. Incremental change is not enough. And I'm not saying that these are the things we have to take on board when we're looking at a movement for health equity. This is just to inform our discussion. This is the kind of currency, the vocabulary that gets used when we're talking about social movements. Collective action driven by shared goals. It's spontaneous and self-organizing. I mean, that's one that I can recognize, but then when I'm in a job as a DPH, as I was then, or in whatever roles we now currently have, where we tend to plan things, and spontaneous and self-organizing is sometimes not our strength. But there's a recognition that many movements arise from that. Need to be organized. If you're going to stay in existence, you need a central coordinating and resourcing as well. Protesters seeking to influence. Polarization can have a strong impact on bringing participants together. It's the kind of change movements pursue require some measure of sustained organized activity. So that thing coming back to being durable again. You can have the initial passion that gets things going, but if you're going to continue and be successful, you need to make it sustainable. So this is the last slide coming up. It's quite an interesting one. Again, I've mislaid the reference for this. So the movement cycle. emotional state at the side, so growing public anger. There's a trigger event often that people have a sense of injustice about. So you get that uprising, you get that heroic phase, and then the honeymoon, and often there's the disillusionment. And the thing then is about keeping the movement going, learning and reflection, regrowth of the movement as well. So that's all I've got in terms of the slides I wanted to go through today. So I will come back on screen. And as I say, that's not how we necessarily do it. Those are the things we can take account of when we're looking at our movement for health equity. So while I look at what's in the chat, who would like to begin first? Please just raise your hand and we'll come to you. Please go ahead, Duncan.
Hi, thanks for that, Alan. So I was just really thinking about those characteristics. I think were really useful because a bit of the work we've been doing in Bradford District over the last year is building an Inequalities Alliance, and I went to the Birmingham event, and it's got really similar aims. So it's interesting reflecting on what those core characteristics are. And for me, the really important one there was the sort of spontaneous bit, and and trying to get things going that are organised. Like the sort of almost the greatest thing that you can do is see something that somebody said they did because of your movement, but you have no knowledge of at all. And I think that's the trigger point is when I think this is where the building blocks stuff from the Equity Foundation is really useful, because those definitely sort of helped us in terms of framing inequalities in a completely different way, because people were getting really desolate and you know, they were just getting very down when we started saying it's too big. So really trying to hone it down into the bite-sized chunk for what that person can do in their service, in their community or whatever, and then just saying off you go. That's the real thing that we've found. We're trying to do all the organised usual public health things that you do and set metrics and outcomes and all that. We're doing all that as well in the background, but we wanted to do something more than that, and it's the spontaneity that I think is the key ingredient.
If you don't mind, Duncan, if I can just ask you a few questions about that word, that sounds very interesting. What do you do to set the context for that spontaneity to arise? How do you go about it?
Well, we've done it. We've used. We're trying different things to see which work. We've done some sort of open space sessions where you get people to sort of self-organise in rooms, get people to stand up and say what they're passionate about, and then get them to self-organise. And then people literally vote with their feet, and they go to tables, and they get a sort of little mini action group together for one action that they identify. That works really well, but there's quite a big decay in terms of when we followed that up, you know, 3 or 4 months later, there's probably only 15 or 20% of those groups that are still talking to each other. But that was good. And I think the other thing was using the building blocks more with community activation. So we're starting to use participatory budgeting and things like that again, to so that you can get people in a room and literally, like Dragon's Den, bid for some money, get it on the day, get sent the money the next week, and then off they go. So we're trying to get that sort of groundswell going as well. I think there's a few different things. I mean, we're only a year in, so we've no way that we've cracked it, but it's nice to see those sorts of things flourishing, as well as all the work that we're trying to do with the sort of senior boards and in trying to hold them to account. So we're developing like readiness toolkits and things like that to take to boards to sort of say, look, you've got inequalities and these things all over your strategy, but how equipped and how empowered do you feel to actually do that personally in such a difficult environment at the moment, in terms of, you know, sort of local authority and NHS finances. So yeah, just different sorts of things really.
Excellent. That sounds fantastic. And I've tried open space stuff before. It's nerve-wracking. You're not quite sure if people are going to buy into it, but I have found it very useful in the past as well. That's excellent. Thank you very much, Duncan. Anyone else? Any thoughts or queries about what we've just been seeing in the presentation?
Can I just share a reflection on what Duncan was saying, Alan, if that's okay, just very briefly? It's great to hear that you found sort of talking about building blocks so helpful, and we've been really delighted by the uptake of it. One of our IT people showed me how to do a search the other day, where you can search like local government websites and narrow it to that and look for the phrase. And it's amazing how it's been picked up, which is great. And we have heard from people that they have found it helpful in engaging both communities in understanding the wider determinants, but also talking with people across their local systems and understanding sort of their role, as you say, rather than everyone having to understand the whole system, if you like, to know and to realise their role in health, and as you say, engage and ignite something in them to run with. And it's a question really interested in through some other work we're doing on complex systems change and things, and whether everyone needs to understand the whole of the system, or you have someone in some position, maybe as you are, Duncan, who sort of has that overview of the system and can use and ignite people to run with things and keep an eye on what's going on. So really interesting to hear.
Excellent. Thanks very much, Louise. Victoria, and can you just introduce when you come on, introduce yourself and where you're working. Thanks, Victoria.
Yeah, sure. So hi, my name's Victoria Morgan, and I work in the maternity and neonatal programme in NHS England. So for the national team, one of the things I do is to provide policy support to work about reducing health inequalities for mums and babies. And just, it's more a comment, I think, Alan, just to think that Gantt model is really helpful. It's a bit like Duncan was saying earlier in terms of the leadership. It's actually when you hear of people doing things and you didn't know that they were going on, but it's sort of inspired by that work. It's really helpful. And although that Gantt model is about social movements, it does seem to be quite a helpful lens to look at policy work as well. Like all of those things, relationships have been really key, the stories as well as the data is really key, having a very clear theory of change, and then how do we encourage sort of local systems then to take action on the things that we know that work, are all things we've probably thought about. And I don't know if you have any reflections on how useful this could be in a more sort of formal environment, perhaps, that you might say that NHS England or other national bodies might be in.
Yeah, that's an interesting one. Because I'm not entirely sure how able you are in your position to take on that kind of social movement approach. And I suppose it's the kind of thing, if it's mandated from the government, yep, you could do it. But let's not hold our breath. So the way I'm thinking that we will go after this, after this discussion, is to attempt to make it a more formal process where we set about creating a narrative and we start testing it out with people in the network about what the language is that we use. But what I'd really look for from today is some input on that, about what kind of things should we particularly be focusing on. And one of the things that Duncan mentioned is that spontaneity, and what was coming in through the slide set as well is that sense of keeping people's energy up and hope. And so much of the way we discuss these things can be, we'll spiral downwards, and we've got to make sure that we keep the chance of success up and hope up as well. So any thoughts about how we start framing that, to use Louise's term, or any experiences we can draw on that keep that hope high? Please go ahead. So apologies, Hashim or Mahmoud.
Yes, afternoon all, it's Hashim. So I'm a senior policy advisor on population health at the NHS Confederation. Yeah, just building on sort of both Duncan's point and Victoria's point, I think it's something around sort of trying to understand the sort of motivations for change. And I think, if you sort of look at some of what's already out there around the evidence on that, I think there is something around having that sense of direction from, say, national or government around what needs to be required and what sort of how they may facilitate. But then I think at that sort of kind of lateral level, sort of I'm talking about what local systems or organizations could do, there's a lot of learning that can be done in terms of kind of between sort of at that middle sort of level. And then I think the point sort of Duncan made around, and there's a sort of that bottom-up approach in terms of what patients and communities want to and how they can support that change. So I think in terms of that movement, it's sort of how do we align them three motivations to then sort of move and progress in the required change that we want. So I think it's sort of galvanizing the motivations to enable and support the change that we'd want.
Yeah, that's fantastic, Hashim. I like that idea of looking at how we work at those three levels. And I suppose what I try to win myself off is the idea that we need to control them. You exert some sense of control over these things. And at different points in your three levels, that'll be more appropriate than others. But for the bottom up one, I think what we need is to fire up passions then and see what happens, see where it goes after that without trying to actually control anything there. Thank you very much for those three tiers of looking at it. Veronica.
Hi everyone. So I was just wondering, along the same line as Hashim was speaking, so perhaps the movement should try and focus more on the positive side of things and maybe identifying those people who are already doing good work in the space and helping them get greater reach, amplifying their, what they're doing, sharing it with other people and helping them find collaborators and possibly then enabling the growth or the development of that idea further. I think that the network could do that quite well potentially. And it wouldn't then mean we're directing what people are doing. They would be addressing the needs as they see need addressing, but we would be there to kind of support that effort and provide maybe additional information to help them in what they're doing.
Excellent. Could you just say where you work, Veronica, and your job?
Yeah, so I'm a GP currently north of Bristol, but I do a lot of work in the rural health space, both on a European and a global level. Yeah,
excellent. I do think, I can certainly understand the need to focus on the positive side. It's then I think I have to make a conscious effort to make sure we do that. Otherwise, the default is towards the mortality stats and the differences and so on and so forth. And then thank you for pointing that out. The potential role of the network to help give a higher profile of the people who are doing stuff, and then to engage them with others. Excellent idea. Thank you, Tim.
Yeah, really interesting discussion. It's just, I suppose it's a reflection that I think it's really inspiring to hear what everyone else is doing. I think the Health Foundation Frameworks work is absolutely brilliant, and we've certainly, as I mentioned in the comments, really incorporated it and sort of lent on that quite heavily. I think the showing that it's possible and having an optimistic slant to it is massively important. And we see that with the climate change example you use, with just a great sense of fatalism and pessimism about that. It is a real challenge to overcome. The main reflection is, with a lot of those good examples you used, right back to the sort of the kind scale, the cycling one, they're very, very clean, clear. Although the solutions aren't simple, the sort of ambition can be distilled down. Stop kids being killed on road by cars. Be able to walk where you want. Even actually to some extent the Me Too and the Black Lives Matter, obviously hugely complex, but you can sort of distill it down to a certain line. The inequalities and inequity one, I think, is much, much harder to distill down to a clear concept of what you want. So those overlaps and intersectionality between inequalities by deprivation, inequalities by inclusion group, and inequalities by other forms such as geography actually make it a very, very challenging to pin down to a simple concept. And that alignment between what are causes of predominantly health inequalities and what are simple other inequalities for pure inequality's sake, which we're not talking about. So some testing of taking further forward some of that work off the back of the frameworks, and whether there's opportunity to sort of distill, throw around, test some of the sort of messaging and framing of that I think would be really valuable. We haven't cracked that by a very long stretch, and I feel like we get pulled backwards and forwards by it. And you go, you try and simplify down, focus on the deprivation, but quite reasonably you miss the point on some inclusion groups. Other times you go into people think they've ticked the inequalities box because they've got one reference and action on LD, and you kind of have to pull back from that. And it does feel, quite a challenging one. Core 20+5 is, a great attempt to do it, and hats off to them. I think it's really impressive. But it's only a bit of the solution, and it's very, very sector specific to the NHS, and doesn't really address, therefore, the broader social determinants sort of landscape. So, yeah, that was
excellent. Thanks, Tim. And Tim, you're a consultant public health in Leeds.
Deputy Director of Consultant Public Health in Leeds, and leading the sort of Marmot City work over here. Sorry.
I only do that so that people can make connections and possibly follow up after. They're great points about clean, clear goals, and of course we're perfection is the enemy of good, so we just keep trying here to make progress, and success sometimes feels elusive, but there is great work happening. Louise, and then Kenji and Duncan. Louise, you're on mute, Louise.
Clearly I can't cope with putting my hand down and unmuting. I think Tim's probably said most of what I was going to say, actually, but just coming back on this point that Veronica made about fatalism, and that is so important. So, and we really found that in the research that, it's very easy for people to get so fatalistic and just say this is all too big and it's all too complex and there's nothing we can do, and it's just, this is the way the world is. So actually, I think there's a real important role in sort of sharing some of those examples of, however small they seem, things that are starting to break some of this down and make improvements.
Excellent. I'll go straight on to Kenji.
Hi. I'm Kenji Shermer. I'm an urban designer, so coming from the construction industry side of things as opposed to health. So my interest would be creating healthy environments, which is deeply complex, involves economics as well as everything else. It's not just about diggers and spades. The point, I suppose, I was looking at was especially learning from I suppose you could say, the failure of the environmental movement, where the message is actually very simple and the solutions are really quite compelling, even from basic economic and business terms. But yet it seems to have been stuck in the mud for about 70 years. And I think a lot of that is because the messaging has been about us against them, about actors who are bad and evil and us who are good. And it immediately turns off the people who actually have the power to change, because they're the people who've got direct influence on those businesses, when actually it could be a much more positive engagement. So that separation really has to be avoided. And I think the other thing is really about the simplicity of the message, where it has to be that simple that everybody gets it, because it can't be a social movement that just involves professionals. It has to be something that involves absolutely everybody. So there's a general population push, because what we're asking for is so broad, it demands deep policy change and shifts of direction that won't come from professionals. It will come from the general public having an understanding of those issues, to be able to demand something which is incredibly simple. We want longer lives, we want healthy lives. That's it, that's all there is to it. But the solution obviously is a little bit more complex, but the demand has to be broad and deeply simple. And then
excellent.
I suppose you could learn from car adverts as well, because they talk about nothing to do with facts. It's all about, you swim with a shark and punch it in the face and you're a hero. That it's totally daft, but it persuades people to part with a lot of cash.
Yeah.
So how do they win? And environmentalism loses.
Excellent. Really helpful, Kenji, and great to have that perspective from somebody in the construction side of things as well. Thank you very much for that. That polarization issue is one of those core characteristics, and one that I'm not comfortable with, because if one of the 8 points was saying polarization helps to fire up people or something like that, and you kind of think, well, what we need is another referendum, because that, if nothing polarizes as much as having to make a binary choice like that. So I'm with you in terms of polarization often acting against what you're trying to achieve. Duncan, and then Elizabeth.
Yeah, I just want to pick up what Tim and Kenji were saying. So I think that's really, for me, it's the sort of crispness of the message in the event, and I suppose I think there's lots that we can do with a health equity movement, but I suppose I question whether it can be a pure movement in that sense, because it is just a bit broad and vague, and whether we need to be a little bit more precious about a whole systems approach to equity and take off a big chunk, because so sometimes you have negative events that spark positive things. So the Grenfell fire, that could have been the start of a movement, but it hasn't been. We've so if you wanted to just look at equity within the children's world, we had a really tragic death of a young child, baby Star Hobson, that was in the papers. That could have been another thing for polarising around equity within children's services, but we sort of didn't manage it. And I think there does need to be that conflict, but it doesn't need to be. It needs to be sort of conflict against almost like a faceless system is fine, because it probably makes it a little bit easier when the man, if you like, isn't actually a specific person. And I think that's sort of maybe what Benji was getting at. But I wonder, as we take the equity movement forward, whether we need to think a little bit more about that, because I thought the pandemic might be that single event, and we certainly, in a lot of our storytelling, we use the pandemic in Bradford to say, look, if that happens again, would the same thing again happen in Bradford? Would the same thing happen in England? Or can we bottle up that sense of energy and urgency that we had for that 18 months, 2 years, and do it again now? But we haven't got the one thing. Even poverty is really broad. So I suppose I'm just sort of throwing it out there about taking the movement forward and crisping it up a bit.
Yeah, excellent point. And so many of the things that we work on are given a political slant. So even talking about poverty is not necessarily as obvious and straightforward as you'd think. Elizabeth.
Hi, thanks, Alan. Lizzie Walsh, Health Equity Programme Manager at OHID London. Just picking up on Tim and Kenji's points on intersectionality and them versus us kind of framing, I think it's really similar to the Core 20+5. We've got to take a two-prong approach. There's going to be some stuff that's targeted for specific communities, and we need to communicate that and then those issues. But then there are also those intersectional mechanisms that are drivers of inequalities for many communities. And I think there needs to be better understanding around that, and the fact that we're not making communities compete here. And if we work for one community or on the intersectional mechanisms, then we'll be improving things for all. And I think everyone needs to understand that value for all in tackling health equity, to make sure that it's all of our problem and not just the problem of those who are at the fringes.
That's a great point. I'm making notes as I go along here, but that's an excellent point to just bear in mind when we're making developments for a community. We're making developments for all communities. Thank you very much for making that point. Felicity.
Thank you. So I'm Felicity Porritt, and I'm Head of Communications at the Institute of Health Equity. I've worked with Michael since the Global Commission on the Social Determinants of Health, and back then when we were looking at launching that global report and how to get traction in the UK media and the global media, was really tricky, because health inequalities was seen as a bit of a kind of, marginalised, it's about, tackling poverty. So getting traction in the media was really quite difficult. We did, though, and we did because of the shocking stats. So what we know in the media is negativity sticks. That's what makes the news. And that's what's turning everybody off watching the news at the moment, because it's so overwhelming. So firstly, I just wanted to make the point about, journalists, and I'm a former journalist myself, BBC, it is about those negative news stories, and we get the positive ones right at the end, the cat stuck up by the tree and, the local farmer rescues it, etc. And absolutely, it's about building hope, because, we so need hope. If we look at, climate, if we look at any big sort of social movement right through to change, and probably tobacco is probably the best one, but it's such a simple one because it's a simple message. So two things to say about that. Firstly, a simple message. It took 50 years to get to the WHO framework on tobacco control. So it takes time to bring everybody together. and it requires us all to work together. And then just touching on the point about the car industry and the shark, the reason that they're able to do that, of course, is because they've got huge deep pockets and they spend money on adverts that are repeated time and time again. And within public health, we don't have those deep pockets. If in terms of the general public, you want to get traction with the general public, not everybody reads. So, you know, visual, understandable, simple messaging is absolutely key. And it's about repeating that, which is where the news media comes in, and then it gets dragged down by the negativity. So it's how we break that loop to, or maybe use that loop to, you know, to rise up and shift on from where we've got today, which I think is phenomenal, given that in 2008, you know, health inequalities weren't even covered in the media.
Yeah.
Thank you.
Thanks very much, Felicity. Excellent points. And we do need to take account of, or make use of that kind of inside knowledge about how journalism and that aspect of communication all functions. So I've just been going over the chat, trying to catch up with that. There is some fantastic stuff in there. Would anyone like to say something about the post they've made? There's Orla's post about the work in Salford, Elizabeth's work in Hearts. Edward was making a point. Would you like to come on and just say a bit more? And you don't have to, but
hello.
Go on, Orla. Good to see you.
Hi. Yeah, I thought I would get away with not having to speak, but I'm happy to talk about it if it's interesting to people. But
yeah,
I'm the project manager for the Economies for Healthier Lives project in Salford, which is currently funded by the Health Foundation. And we are running a community wealth building project that's co-production between local people and agencies, where we are looking at how the anchor institutions in Salford spend their money year on year, and looking for any opportunities where local people can become the suppliers to those sort of goods and services as well. And on top of that, we're also helping the local people involved to create the social enterprises based on the sort of market information that we've got from the anchor institutions as well. So we're about just over 18 months in, so we're at the stage now where they're sort of identifying those real opportunities, and they'll be starting the business setup from January next year as well. But we've created a Substack platform just to sort of share what we're doing. And just because obviously in economic development, local people are often left out. And so the whole, it's around co-production with local people, and it's all about health improvement and tackling health inequalities as well, community wealth building, community health building kind of thing. So yeah, if anybody wants to check it out, we've just published one chapter at the moment last month. The next one will be coming out next week, so it's a good time to subscribe now. It'll come straight into your email, and then we'd love to hear from you. If you have any comments or questions, please get in touch with us. We'd love to learn if anyone's doing anything similar that we can learn from, or if you have any particular questions about what we're doing, we're happy to discuss anything you've read further or heard about. But yeah, thank you.
Excellent. That's fantastic, Orla, and a project, a national program that I was I'm familiar with too. So great to see that that's working. Of course, you could publicise it, maybe you already have done, on the Health Equity Network, and provide more information there too. You'd be very welcome to do that. Okay. Any last takers? If there's not, there's only one thing I can guarantee every time we do these webinars, it's that we'll end on time. So I will draw it to a close there. Next steps is that we will now be putting some of this into writing, offering that back out to the network again to help us refine what the story is, what the message is. There's some great ideas in the chat that we'll be picking up on. Thanks, Duncan. And just to say also a plug for the next webinar, which is on the, Alison, tell me right, 13th of December, 12:30 to 1:30. And this is going to be a webinar where you can write your kind of Christmas wish list for what you would want an incoming government to put into practice, into policy, into investment to address social determinants of health, given that we are moving into an election year in 2024. So please do join us for that. And thank you very much for contributing on the chat, contributing in person, and hope to see you in a month's time. Thanks very much. Bye.
Thanks, Alan. Thanks all.
Bye.
Thank you so much. Thank you. Bye-bye.
Thanks, everybody.
Thank you.